Mr. Chairman, ladies and gentlemen, first of all, I would like to thank the organizers, Professor BISMUTH and Professor ZIENIEWICZ, for the kind invitation to this very interesting meeting. My topic today is contemporary challenges in the management of primary sclerosing cholangitis. This is the chronic cholestatic liver disease, which presents itself with multifocal bile duct strictures, which may affect both intrahepatic and extrahepatic biliary tree. It occurs more frequently in young adults, particularly male patients. Its etiology is multifactorial, with autoimmune, genetic, environmental, and possibly infective factors all playing their role. MRCP is a gold standard in the diagnosis, and there is no curative treatment, and prognosis remains uncertain. There is high risk of cholangiocarcinoma, and the disease is very strongly associated with inflammatory bowel disease, in particular ulcerative colitis, affecting up to 70% of patients. In terms of treatment, despite all these controversies, vast majority of doctors start from ursodeoxycholic acid. The second step would be therapeutic endoscopy, and if therapeutic endoscopy fails, then the patient should or could be considered as a liver transplant candidate. There are several challenges in the treatment, in the management of those patients. They for sure include the differential diagnosis with other conditions which present themselves with biliary strictures, diagnosis and treatment of patients with PSC who also have features of autoimmune hepatitis, timing for liver transplantation. There are some post-transplant challenges, and obviously the biggest challenge in this condition is screening for cholangiocarcinoma. So let's start from differential diagnosis. IgG4 cholangiopathy has emerged recently as an important clinical topic which may mimic primary sclerosing cholangitis. The new diagnostic criteria has been published a couple of months ago, coming from Japan, and this disease, in comparison to PSC, may present in a bit different pattern of strictures we see on MRCP. This is what you can see on this picture from the textbook and from the new guidelines. Obviously, the picture looks very nice in the textbook. However, in the real life, we may have some problems in differential. IgG4 cholangiopathy affects more commonly older patients. There is no association with IBD, and there is a frequent involvement of other organs because this is a systemic disease. Positive IgG4 in terms of thresholds, there are discrepancies between Japanese and European studies. What makes this condition different from PSC is a very good response to the treatment with steroids. There's also less risk of cholangiocarcinoma, affecting up to 2% of patients. However, there is an increased risk of pancreatic cancer in up to 5% of patients. So here is an example of one of our patients who was referred to us, and we diagnosed him with IgG4 cholangiopathy, and you can see a very good response to the treatment with steroids. Here is another patient who was referred to us for the second opinion. This patient was initially diagnosed with hilar cholangiocarcinoma and PSC. Our radiologist diagnosed something different, actually diagnosed IgG4 cholangiopathy. We put him on steroids, and after 3 years, we can see the patient is pretty stable, the strictures are less pronounced, and the patient is doing fine. Second important challenge in this condition is for sure diagnosis and treatment of patients with PSC who also present with some features of autoimmune hepatitis. And here we can see a definition of this variant, autoimmune PSC. Some people call it overlap. So according to EASL definition, you should have a patient with the overt cholangiographic or histological features of PSC alongside robust features of autoimmune hepatitis. And here is the study we performed last year within International PSC Study Group. And in this study, we asked 80 experts from 23 countries, 5 continents, how do they actually handle and deal with patients with PSC and possible autoimmune hepatitis. And what we found was that there are huge discrepancies both in the diagnosis and in the treatment of this patient. So for sure, there is no uniform approach. For example, some experts would treat these patients with steroids, others wouldn't. Some would do the biopsy, others wouldn't. So our conclusion is pretty gloomy, because in conclusion, we said that there is a significant variability in practice and a lack of clarity and consensus for care of patients with PSC and features of autoimmune hepatitis. This is a real problem in everyday clinical practice in several centers. Then timing for liver transplantation. We all know that significant proportion of patients who are referred for transplantation actually do not have end-stage liver disease. I think in our cohort, it will be about 50% of patients, and the major indication is obviously recurrent cholangitis, and extremely, very rarely, pruritus as a sole indication. Many centers in Europe and in US introduce standard exception. This means that those patients with PSC are very unlikely to score high MELD scores, so they got additional points which are added to the MELD score. And obviously, the challenge and controversy is also related to the mode of biliary anastomosis. Should it be Roux-en-Y, or can they be reconstructed in duct-to-duct mode? There are some reports suggesting that duct-to-duct reconstruction can be performed in patients with PSC. However, unlike the sentence coming from this large meta-analysis comparing both approaches, which says that duct-to-duct reconstruction should be considered when feasible in patients with PSC. Well, I don't know how often it is possible and feasible, because vast majority of patients with PSC also have heavily involvement of common bile duct in this condition. And if it's done duct-to-duct, as you can see on this picture, you can see a florid recurrence of PSC in patients who are transplanted duct-to-duct. So I believe this remains a controversy, but this is a surgical problem, and I'm just a simple hepatologist. Recurrence of PSC. Here you can see the largest study done in the UK. This is a multi-center study, almost 680 patients. As you can see, 14% of them developed recurrent PSC, and half of them actually lost their grafts due to recurrence. So as you can see on the graph, there's a significant impact on survival when your patient develops recurrence of PSC. Risk factors which were identified as a risk factor for recurrence is the presence of ulcerative colitis. In fact, PSC do not recur in somebody who does not have ulcerative colitis or had colectomy, for example, for ulcerative colitis before transplantation, and younger age is also a predisposing factor for the recurrence. Another important thing in the context of transplantation is an improvement of symptoms. Basically, we're doing transplantation also to improve patients' well-being and quality of life. And here is our own data, which we published a couple of months ago in liver transplantation. We looked at 90 patients who were transplanted for PSC. In our unit, we have a protocol which includes a very detailed analysis of various aspects of quality of life. So we perform a battery of appropriate questionnaires. So we are in a good position to actually assess whether transplantation has affected patients' quality of life after transplantation. So all our patients had the quality of life tests done before transplantation and then sequentially after transplantation. So what we found in this study, that there was a general symptomatic improvement. It refers to general well-being tested with appropriate tests, disappearance of pruritus. However, we didn't see an improvement in chronic fatigue. We all know this is a really debilitating symptom, which may absolutely have a devastating effect on patients' life. So what we found was that despite an improvement with other factors, there is no improvement in chronic fatigue, particularly in female patients. So that's an important point for us when we talk to the patient before transplantation, and if this is a female. And so we have to mention that if she's got a chronic fatigue, this symptom, actually this particular one, is very unlikely to disappear after transplantation. And screening for cholangiocarcinoma, for sure, the biggest challenge we face in this condition. Cholangiocarcinoma, we all know, is an aggressive tumor with bad prognosis. In MRCP, it's really difficult to distinguish cholangiocarcinoma from inflammatory lesion at the early stage of the tumor. Cholangio affects up to 12% of patients with PSC, and this proportion actually rises to 20% in patients suffering from the disease for more than 20 years. Can be considered as an indication for liver transplantation in very highly selected patients. Such patient actually was transplanted a couple of days ago in a center, and there are limited treatment options in cases which are not resectable. So what do we have? There are no reliable screening methods available. CA19-9 could be of use only in combination with other modalities. We all know that CA19-9 can be sky high in patients with just cholangitis and no tumor whatsoever, and could be completely normal in somebody with advanced cholangiocarcinoma. Again, what I said before, in MRCP, it's really difficult to distinguish from inflammatory lesions at early stage of the tumor. So what do we do? Brush cytology during ERCP procedure has a very high specificity of 97%, however, pretty low sensitivity of 43%. And sensitivity increases when we support ourselves with FISH, so in situ hybridization, to 68%. Spyglass biopsy, very high specificity of 100, however, sensitivity pretty low of 33%. So there are lots of efforts actually to tackle this problem, and all possible body fluids and tissues are analyzed. And I'd like just to finish with 3 studies in which we were involved at the center, trying to improve our prognostication capacity in this respect. This is the study we coordinated within ERN, European Reference Network, Rare Liver Network, where we looked at the potential predictive role of 2 autoantibodies, anti-PR3 and anti-GP2, in patients with PSC. We had 2 study groups. Our analyzed cohort, more than 300 patients with PSC from our center, and validation cohort, approximately 200 patients from Hamburg. What we found was that there was a significantly worse prognosis in anti-GP2 positive patients, and of interest, all patients who developed cholangiocarcinoma were positive for either anti-GP2 and anti-PR3. Well, this is a very tiny step forward, but still, I think this is a step forward, and maybe our battery of tests for early picking up cholangiocarcinoma may in the future include those 2 autoantibodies. That's another study. We are very privileged to have a chance to collaborate for many years with Jesus Banales and his group in San Sebastian. So Jesus and his colleagues are able to isolate serum extracellular vesicles. And in this project, proteomic analysis showed different expression of proteins in PSC and cholangiocarcinoma. So the conclusion was that proteomic signatures found in serum extracellular vesicles show potential usefulness as a diagnostic tool in the diagnosis of cholangio in patients with PSC. This paper is very highly cited. I believe there is a potential in this method. And the last study I'd like to mention today is the paper published just a couple of weeks ago, which is coordinated by Matias Avila, again from Spain, from Pamplona, and Professor ZIENIEWICZ and my group took part in this study. This is a mutational analysis of cell-free DNA in bile obtained during ERCP procedure. Matthias called it BILEMUT. This is basically NGS assay. I don't want to go into details, but what was found was that sensitivity for malignancy in patients with initially diagnosed benign or indeterminate strictures was 100%. Very impressive. However, this has to be validated, and Professor ZIENIEWICZ and his endoscopists and my colleagues are working now very hard to produce a validation study with much larger cohorts of patients. So conclusion from this study is that the implementation of BILEMUT at the initial diagnostic stage for biliary strictures can significantly improve detection of malignancy. We hope there is a great potential in this method. So in conclusion, Mr. Chairman, ladies and gentlemen, PSC remains a mysterious liver condition with several challenges, as I tried to elucidate in my presentation, at each stage of its management, and reliable prediction of cholangio constitutes the critical point in improving prognosis in patients with PSC. Thank you very much for your attention.